So welcome everyone. So the topic of discussion today is otosclerosis, and the topics on which I'll be talking about are introduction, features, types, Etipathogenesis, signs and symptoms, investigations, treatment, and complications of stapes surgery. So initially, what is otosclerosis? Otosclerosis is a primary disease of the otic capsule. So first we need to know what is otic capsule. So a few terminologies. I'll be talking about otic capsule, otic labyrinth, and the periotic labyrinth. Now, otic capsule is basically the bony labyrinth. The bony labyrinth. Within which lie the otic labyrinth and the periotic labyrinth. Otic labyrinth is basically the membranous labyrinth. Where endolymph circulates. And periotic labyrinth is the perilymphatic compartment. So basically where the perilymph is circulating. So otosclerosis involves the bone of the otic capsule, so the bony labyrinth. So it is a disease of the bony labyrinth. What happens is dense enchondral bone gets converted to irregular spongy bone. So coming to the features of otosclerosis, otosclerosis is also called otospongiosis. Because the enchondral bone is replaced by irregular spongy bone. It is inherited in an autosomal dominant fashion. It is more common in females with a male is to female ratio of 1:2. It is more common in the 2nd to 4th decade of life, among which it is commonest in the 3rd decade. And it is the commonest cause of bilateral conductive hearing loss in adults. In children, the commonest cause of bilateral conductive hearing loss in children is otitis media with diffusion. So coming to the types of otosclerosis, otosclerosis is initially divided into two broad types. They are clinical otosclerosis and histologic otosclerosis. Amongst clinical otosclerosis is again of two types. There is stapedial otosclerosis and cochlear otosclerosis. Now, stapedial otosclerosis is the commonest type of otosclerosis, and it presents with conductive hearing loss. Cochlear otosclerosis is due to involvement of the otic capsule of the round window or the bony cochlea, and this presents with sensorineural hearing loss. It is due to release of toxins in the inner ear fluid. So stapedial otosclerosis is again divided into subtypes according to the region of involvement. So if this is the footplate of the stapes, this is the anterior truss, and this is the posterior truss. The commonest region which is affected in case of stapedial otosclerosis is a region just anterior to the footplate, this region, that is called the fissula antifenestrum. Which is also called anterior focus. Now, this is the commonest type of stapedial otosclerosis. According to the region of involvement, stapedial otosclerosis can be of few other types. Like it can be involving the posterior region, which is called a posterior focus. It can involve the margins of the footplate. Then it would be called a circumferential term. Or it can involve the footplate as a whole, but not going up to the annular ligament of the footplate, that is the central part of the footplate. That is called a biscuit term. And finally, when it involves the whole of the oval window area, then it is called the obliterative term. So what is histologic otosclerosis? Histologic otosclerosis is the otosclerosis which does not produce any clinical symptoms. Like after the death of the patient, when we perform temporal bone dissection, we may find different foci of otosclerosis, but it does not produce any symptoms during the life of the patient. That is because it may involve the areas of the otic capsule which are not concerned with hearing. So if there is no difficulty in hearing, it will not produce any symptoms, but the otosclerotic foci may be present in the otic capsule, but they will not produce any symptoms. So that is histologic otosclerosis. So coming to the etiopathogenesis of otosclerosis. Otosclerosis, to basically the exact cause of otosclerosis is still not known. There are many theories which have been proposed, and they try to explain the disease process in different ways. So few of the factors which are related to the development of otosclerosis are: first, let us try to understand the anatomy of the otic capsule. Now the otic capsule has 3 layers. The bony otic capsule has 3 layers. The inner endosteal layer, then the enchondral layer, and the outer periosteal layer. Now, the enchondral layer develops by the ossification of cartilage. So in the intrauterine life, the enchondral layer is basically a plate of cartilage which usually gets ossified to form the enchondral bone. So what happens is, if there is incomplete ossification of the enchondral layer, there may be plates of cartilage remaining in the enchondral layer of the otic capsule, which may ultimately give rise to a spongy bone from those cartilages. So this can be a cause of otosclerosis. Now other factors which are commonly found with otosclerosis are, like there's a role of, as I mentioned before, it is a autosomal dominant pattern of inheritance. Otosclerosis has an autosomal dominant pattern of inheritance. So there are many hereditary factors. There are certain racial factors, and obviously, as I mentioned before as well, the sex, it is more common in females. Now, an associate disease, a combination of syndromes where otosclerosis is associated, is Van der Waals syndrome. What is Van der Waals syndrome? So, Van der Waals syndrome is a triad of osteogenesis imperfecta, blue sclera, and otosclerosis. Now, osteogenesis imperfecta is due to a defect in type 1 collagen. Again, in otosclerosis, in the spongy bone, defective type 1 collagen is found. So, this has been linked in many theories, like otosclerosis develops from a defect in the type 1 collagen. So, coming to the signs and symptoms of otosclerosis, to understand the signs and symptoms, first we need to understand what is active otosclerosis. Now, when there is an ongoing process of conversion of enchondral bone to spongy bone, that is, the process is still going on, that situation is called an active otosclerosis. So, during that situation, we see a specific sign in the tympanic membrane which is called the Schwartz sign. We won't see this sign in a patient of otosclerosis if there is no active focus of otosclerosis. So, what is Schwartz sign? When there is an active otosclerotic foci present in the biliary cavity or the otic capsule, those regions will be highly vascular, which produce a pinkish hue of the tympanic membrane. More commonly, it involves the posterior-inferior part of the tympanic membrane. Okay, so this is called Schwartz sign, and this is called a flamingo pink tympanic membrane. Then coming to the other signs and symptoms of otosclerosis. So first of all, there will be a hearing loss. Now the hearing loss is mostly bilateral and conductive, but if there is an involvement, and sometimes it may be unilateral, or if there is an involvement of the cochlea, so the otosclerotic foci has involved the cochlea, in those cases it will have a sensorineural hearing loss or a mixed hearing loss. So all three types of hearing loss may be present in otosclerosis, but is most commonly present with the bilateral conductive hearing loss. So then coming to a feature of otosclerosis which is unique for otosclerosis is what is called paraacusis willisi. So what happens is the patient hears better in noisy surroundings. Why does this happen? We naturally raise our voices in noisy surroundings. So as the air conduction threshold of the patient has increased, so when we raise our voice, the patient can hear better, and so the patient says, when I go to noisy surroundings I can hear, but in normal conversation I cannot hear. So that symptom is called paraacusis wheezy. Then the speech of the patient will be a soft, monotonous speech, and rarely it may also have tinnitus and vertigo. So coming to the investigations that we need to perform for otosclerosis. Now here I will talk about the tuning fork tests as well, although they are not investigations per se, but tuning fork test helps us in a proper diagnosis of otosclerosis. So coming to the tuning fork test, so first of all the Rini test, it will be Rini negative. I am talking about the tuning fork test findings of stapedial otosclerosis. It will be Rini negative because there is a conductive hearing loss. Now Weber's test will lateralize to the disease side. Again due to the conductive hearing loss. In stapedial otosclerosis, when there is no involvement of cochlea, the absolute bone conduction test will be normal, that is equal to examiner. The Schwaback test will increase again due to a conductive hearing loss, and Gillies test will be negative. So then coming to the investigations, I have shown a ear-tone audiometry curve. Now feature of that is usually found in otosclerosis but it is not specific for otosclerosis is what we find in the audiometry is a Carhart's notch. It is a dip in the bone conduction at the level of 2000 Hz. It is called a Carhart's notch. Now this is not specific for otosclerosis. It can be found in other situations as well, like tympanosclerosis and even ossicular fixation. And as you can notice, this is the bone conduction curve, this is the air conduction curve. The air conduction, the loss is more in the lower frequencies. Loss is more in the lower frequencies. This is the frequency and this is the hearing loss. So it is the hearing loss is more in the lower frequencies. So this is the air conduction curve and the bone conduction. Then after pure tone audiometry, we can do a tympanometry. Initially, the tympanometry will give you a A-type curve, and later on it will give an AS type of curve. All of this is for stapedial otosclerosis. Then impedance audiometry. In impedance audiometry, we will get a negative stapedial reflex test. It is due to the fixation of the stapes foot plate. So even when there is a contraction of the stapedius tendon, the stapedial reflex will be negative because there is no movement of the foot plate. So, and finally coming to the final investigation that we rarely perform, but it gives you a good idea about the location of otosclerosis, is HRCT scan of the temporal bone. So the otosclerotic foci will come as a hypodense areas. And if there is stapedial otosclerosis, there will be a narrowing of the foot plate of stapes. So coming to the treatment of otosclerosis, now active otosclerosis is treated medically. So in active otosclerosis, when there is increased osteoclastic activity, we need to give sodium fluoride. What does sodium fluoride do? It decreases the osteoclastic activity and increases bone formation. So there is maturation of the active otosclerotic foci. After that we can, so this is the medical management which is only a role in active otosclerosis. Then after maturation of active otosclerosis we can go for surgical treatment. Now in surgery we have two options. Basically we used to have three options, but the third option is no longer used nowadays. It was type 5 tympanoplasty, where we used to bypass the stapes foot plate. You can refer to my video on tympanoplasty if you want to know about details of type 5 tympanoplasty, but it is no longer done. The other two options that remain are stapedectomy and stepidotomy. Now, in stapedectomy, what is done is there is complete removal of the stapes. We remove the suprastructure, we remove the foot plate as well. So what happens? The oval window is exposed. So it can lead to a perilymph leakage. Which will ultimately cause vertigo. So nowadays the role of stapedectomy is also a little questionable. Now, the surgery which is preferred is stepidotomy. What do we do in stepidotomy? So we cut the stapedial tendon. Then we dislocate the incutostapedial joint. Then we only remove the suprastructure. The foot plate is in place. So the foot plate is intact. And a small hole is made on the foot plate, through which we place a piston which is hinged with the incus. Piston to incus. So the vibration of the tympanic membrane will again cause vibration of malleus, then the incus, then the piston will transmit the vibrations to the inner ear. So basically the stepidotomy is the preferred mode of surgery nowadays. Now I mentioned a few of the complications already in the while talking about these two types of surgeries, like perilymph leak in case of stapedectomy. So I am now going to go into details about the complications related to stapes surgery. So coming to the complications of stapes surgery, the stapedectomy or stepidotomy. Now again, after a successful operation there is improvement of hearing after surgery, but there may be again a refixation of the foot plate. So again the patient will land up in a situation of conductive hearing loss. Now in case of stepidotomy, there may be dislocation of piston. Now these two are more during stepidotomy. That is due to the piston. They may get dislocated. So when there is dislocation, there will be again a ossicular discontinuity. So the patient will have a conductive ear impulse. Or if the piston is too tightly attached to the long process of incus, there may be necrosis of the long process of incus. Now these two are due to damage to the foot plate and when there is perilymph leakage. Now they can happen in both stapedectomy or stepidotomy. These are more common after stapedectomy when we completely remove the foot plate, and then in those cases when there is damage to the oval window membrane, then due to the perilymph leakage there will be a vertigo and a sensorineural hearing loss. And this is more in stapedectomy. Now there may be nerve injury, the facial nerve injury and the chorda-tympani nerve injury. Now chorda-tympani nerve injury will occur while elevating the tympanomeatal flap, and the seventh nerve injury will obviously, the seventh nerve lies in close proximity to the stapes foot plate. So during operation we might injure the facial nerve, and in many cases the patient may end up in a dead ear. So basically, when you have damaged the oval window too much, then due to a persistent perilymph leakage, the patient will end up in a situation with a dead ear. So basically the cochlea is no longer functioning. Now this is a little rare complication, but it is quite important as well, is a reparative granuloma. What is a reparative granuloma? It occurs due to more in stepidotomy, and it is suspected, though a clear etiology is not known as of yet, but it is suspected it is due to foreign body reaction from the piston. So it usually presents 1 to 2 weeks after the stapes surgery, and in those patients we have to immediately go for a re-exploration and repeat surgery. So that is a little rare complication, and it is suspected that it is due to the foreign body reaction of the piston, and this is called a reparative granuloma.